I want you to try something for a second. Just bring your awareness to your body right now.
Yeah. Notice how you're sitting.
Right. Whether you're in a chair or on the couch, maybe you're commuting. If you've been sitting there for more than a few minutes, chances are you've already shifted your weight.
Oh, definitely.
You've, crossed your legs, leaned to one side, maybe adjusted your posture just a fraction of an inch. And you did it completely instinctively.
Without even thinking about it.
Exactly. Your brain received this really subtle, practically invisible signal that a certain part of your body was experiencing too much mechanical pressure, and, well, it made you move. But what happens if you can't?
That's the big question.
Right. What happens when a patient is trapped in that position and that subtle warning system is just broken? So today we are doing a deep dive into a hidden, surprisingly fast mechanism that literally crushes human tissue from the inside out.
Yeah, and the breakdown of that subconscious feedback loop, it opens the door to a genuinely dangerous area of medicine. I mean, when you lose the ability to shift your own weight, the consequences are severe.
And fast, right.
So fast, much faster than most people realize. We were talking about hours, sometimes even just minutes, to trigger this whole cascade of tissue death.
Which is terrifying. So we're jumping straight into the pathophysiology of pressure injuries today. We're going to unpack the hidden mechanics of how sustained pressure kills tissue, look at some of the historical missteps that, quite frankly, blinded brilliant doctors for over a century.
Well, history's wild.
It really is. And we'll explore why some of the most intuitive-sounding medical treatments are actually causing active harm to patients today.
Because the physics and the biology of how this happens, they're incredibly counterintuitive. I mean, it sounds like a straightforward equation, right? You press on tissue too long, it gets damaged.
Makes sense on the surface.
Right. But the moment you look under the surface,
Yeah.
literally and figuratively, everything you think you know about how skin and muscle react to gravity is probably wrong.
To really get a grip on how deceptive this condition is, I think we need to look at a major shift that just happened recently in the medical community. Because for most of the 20th century, these were known as pressure ulcers, right? Or decubitus ulcers.
Yeah, decubitus coming from the Latin for to lie down.
Right. But in April 2016, the major professional body for this, the National Pressure Ulcer Advisory Panel, they completely changed their own name.
They did.
They became the National Pressure Injury Advisory Panel. They deliberately swapped out the word ulcer for injury.
And that was a shift entirely driven by clinical reality. Think about the word ulcer for a second. The moment you hear it, you naturally picture an open wound, a visible break in the skin.
Like a crater or something.
Exactly, like a crater. But the earliest phase of this condition, what clinicians call a stage 1 injury, it doesn't involve an open wound at all. The skin is completely intact, it just looks red, and crucially, it won't blanch.
Okay, blanching. Meaning if you press your fingertip against that red spot on the skin, it doesn't temporarily turn white like normal skin does. It just stays stubbornly red.
Yeah, and that lack of blanching is a massive red flag. It tells you the blood flow in that specific localized area is fundamentally compromised. So calling that state an ulcer was factually inaccurate for a huge percentage of cases where the skin hasn't even broken yet.
Because there's no open sore.
Exactly. And worse, it created this false sense of security. It implied that if the skin wasn't broken, well, things weren't that bad yet.
When in reality, for some of the most dangerous cases, the skin looks absolutely fine on the outside, but the tissue underneath is actively dying.
Actively dying, yeah.
So changing the term to injury forces everyone, doctors, nurses, family caregivers, to recognize that the damage is happening beneath the surface, regardless of whether you can see an open wound.
So let's look at the actual plumbing of the human body to understand why that surface-level skin can look fine while the tissue below is dying. Our cells require a continuous, uninterrupted supply of oxygenated blood to survive.
Right.
And that blood is delivered by this massive network of capillaries. These are the smallest blood vessels in the body, and their walls are incredibly thin.
Like microscopic, right?
Often just a single cell thick. Because they are so microscopic, they are fragile and extremely easy to compress.
So if the external mechanical force pushing against your body, like, say, the weight of your own torso pressing your hip into a mattress, if that exceeds the internal pressure of the blood flowing through those tiny capillaries, they just give up.
They simply collapse flat. The blood flow hits a literal roadblock and stops. This instantly starves the downstream tissue of oxygen, which is a suffocating state we call ischemia.
Ischemia, okay.
Yeah. And if that ischemia lasts long enough, the cells exhaust their energy reserves, toxic waste products build up, and the cells just begin to die.
There's this classic study from 1930 that put a hard number on this, which I found fascinating. A physiologist named Eugene Landis figured out a way to actually measure the blood pressure inside human nail fold capillaries.
Which is wild to think about doing in 1930.
Right. And he found that the mean pressure at the arterial end of the capillary loop was around 32 millimeters of mercury. So for decades, that number 32 millimeters of mercury became the ultimate textbook threshold.
And, modern researchers view that number as a useful rule of thumb rather than an absolute law of physics, simply because capillary pressure varies depending on the person.
Sure, like their overall cardiovascular health or what part of the body we're talking about.
Exactly. But 32 remains this really striking anchor point to keep in mind, because it is an incredibly low amount of pressure. A fully grown, ordinary adult lying perfectly still on a standard hospital mattress easily generates pressures well above 32 millimeters of mercury.
Especially at those bony areas, right?
Yeah, the heels or the sacrum, that triangular bone at the very base of your spine, right above your tailbone.
So is this essentially like stepping on a garden hose in your yard? The water, or the blood in this case, just hits that physical compression wall and stops flowing. The grass on the other side of the kink doesn't get watered.
That's a perfect way to look at it.
Yeah.
Imagine stepping on that hose for a minute. The grass is fine, but step on it for 4 hours and the grass dies. That's the reality for an immobile patient.
Wow.
The terrifying takeaway here is that capillary collapse isn't some rare freak accident that only happens under extreme weight. It is the default state of the human body resting on a surface.
The default state.
Yeah. Within minutes of lying still, the microscopic garden hoses under your bony prominences are completely crushed shut.
Okay, wait. If it happens in minutes and the mechanics of crushing a tiny tube are that straightforward, why did it take medical science over a century to actually understand this?
Well, the immense gravity of medical authority can sometimes create a black hole for progress.
I love that phrase.
A very famous, heavily influential doctor essentially derailed the entire field for decades because his theory was treated as undeniable gospel.
We are talking about Jean-Martin Charcot, right? The towering 19th century French neurologist.
Okay.
So in the 1860s and 70s, Charcot observed that patients with severe spinal cord injuries were developing massive, horrific skin breakdown. But he noticed these injuries were happening even in areas that didn't seem to be under obvious, intense mechanical compression.
Right.
So he formulated what he called the neurotrophic theory. He argued that the spinal cord damage itself caused a failure in the nerves that keep skin healthy, a trophic failure.
Yes.
He blamed disrupted nerve signaling as the root cause, almost entirely dismissing mechanical pressure.
And Charcot's authority in neurology was absolute. Because he said it was a nerve issue, the entire medical establishment just nodded along. For decades, this neurotrophic theory overshadowed the much simpler mechanical explanation.
Just because of his reputation.
Pretty much. It delayed clinicians from focusing on the one variable they could actually control, which was how long and how hard a patient's tissue was being physically compressed against a bed.
But hold on, Charcot was a genius in his field, right? Was he just completely making things up? Or was there some truth to this nerve damage theory that just got blown out of proportion because he was only looking at severe spinal cord patients?
He definitely didn't make it up, and he wasn't entirely wrong. Modern science does confirm that severe nerve injury changes tissue vulnerability.
Oh, really?
Yeah. When nerves are severed or severely damaged, it alters the autonomic vascular responses in the area, the body's automatic ability to dilate or constrict blood vessels to protect tissue. So a paralyzed limb is actually more vulnerable to damage.
Okay, so he saw something real.
He did. Charcot's error was elevating that contributing factor to the sole primary cause. He overstated the case so strongly that it blinded an entire generation of doctors to the basic physics of the garden hose analogy.
And it actually took until 1959 for the mechanical theory to get undeniable, quantifiable proof. A physician named Miroslav Kosiak conducted animal experiments using dogs to map out exactly how pressure destroys tissue.
Kosiak finally measured what observant nurses had suspected for a very long time. By applying carefully controlled pressure to the dogs, he proved there is a strict inverse mathematical relationship between pressure and time.
Meaning
He showed that applying a massive amount of pressure for a very short period caused the exact same degree of cellular death as applying a much lower pressure for a very long period.
Oh, the famous pressure time curve.
Exactly. That curve changed the world of patient care. It is the foundational reason why the instruction to reposition the patient evolved from a vague, nice-to-do suggestion into a mandatory, rigorous medical intervention.
Because it's on a timer now.
Right. Kosiak gave the medical field the data, proving that time is just as destructive as weight.
And the research didn't stop with just straight downward pressure either. In the 1970s, Stephen Dinsdale took this further with pig models and introduced a terrifying new variable into the mix, which is shear.
Oh, shear is an absolutely critical force to understand, and it's much more destructive than simple compression.
How so?
Well, compression is a weight pressing straight down, perpendicular to the bone. Shear occurs when tissue layers slide against each other in opposite directions.
Okay, I'm trying to picture that.
Imagine a patient propped up in a hospital bed reading a book. Slowly, gravity pulls their heavy skeleton and deep muscle tissue downward toward the foot of the bed. But their outer layer of skin is trapped by the friction of the cotton bed sheets.
So the skeleton is moving down, but the skin is staying put.
Exactly. The skeletal structure slides, dragging the deep muscle with it while the skin remains anchored. This dragging motion violently stretches kinks and tears the blood vessels connecting the layers, like rubber bands being pulled at an angle until they snap.
That sounds incredibly painful.
It is. And Dinsdale proved that when you add this shearing force to the equation, you cause vastly deeper damage, and you cause it at much lower pressure thresholds.
Okay, if the damage is starting deep against the bone, completely invisible to the naked eye because of shear and deep capillary collapse, how on earth is a nurse supposed to know a patient is in trouble? I mean, we touched on this with the name change to injury, but the way this presents on a patient's body is entirely backwards to how we usually think about wounds.
Yeah, you're referring to the concept of deep tissue pressure injury, often summarized as the inside-out versus outside-in debate. For a very long time, the classical model of a bed sore assumed the damage started at the surface of the skin and worked its way inward.
Which is what you'd expect.
Right, you'd expect to see a red spot, then a surface blister, then a shallow crater, and eventually a deep wound.
But muscle tissue is highly metabolically active. It demands a lot more oxygen than surface skin does just to stay alive. So when those capillaries collapse and the oxygen gets cut off, the skin can actually survive the starvation for quite a while. The muscle cannot.
No, it can't.
The worst damage starts deep inside, right at the hard interface between the muscle and the bone.
It is frequently referred to as the tip of the iceberg phenomenon. By the time a doctor or nurse sees a purple, maroon, or dark bruise-like discoloration on the surface of the skin, they're looking at the aftermath.
Damage is already done.
Exactly. A massive, wedge-shaped volume of underlying muscle and soft tissue has already died and liquefied beneath the surface.
So a nurse looking at skin that appears fine is dealing with a total false comfort. It sounds exactly like looking at a beautifully painted wall in your living room, completely unaware that a slow plumbing leak has entirely rotted out the drywall and the woody studs behind it.
That is a brilliant analogy.
The paint holds the shape, looking perfect, but the structural integrity behind it is completely gone.
Yeah, the skin is often the absolute last place to show the damage, not the first. Once that painted wall crumbles, you realize the house is already structurally compromised. And when we apply this inside-out mechanism to the real world, we see exactly who is at the highest risk.
Right.
Anyone who loses that pain feedback loop, or who is placed in a position where their body cannot compensate, is in immediate danger.
So you mean like someone under heavy anesthesia during a long surgery?
That is a prime example. Imagine a patient undergoing a complex operation lasting 4 hours. They're completely immobile, positioned on a hard operating room table with minimal padding.
And their entire body weight is resting directly on their sacrum, their heels, maybe the back of their head.
Right. Not only can they not physically shift their weight, but the general anesthesia heavily blunts the body's natural vasoconstrictive responses. It completely turns off the neurological pain signals that would normally force a person to toss and turn.
So they're completely defenseless.
Totally. Perioperative pressure injuries, those acquired during surgery, are a massive category because the immobility is total, prolonged, and imposed entirely from the outside.
That makes perfect sense. And obviously another major at-risk group brings us right back to Charcot's early observations, patients with spinal cord injuries.
Yes. For someone with paraplegia or quadriplegia, the sensory feedback loop we talked about at the very beginning, the one that makes you casually shift in your feet, is permanently disconnected.
Which is hard to even imagine.
Able-bodied people shift dozens of times an hour, even when they are dead asleep. Without that automatic reflex waking you up or forcing a micro-movement, pressure injury is a constant, lifelong threat. It is a daily reality they have to manage with specialized cushions, timers, and just constant vigilance.
Hearing how changing the position of the body dictates where the damage occurs, it instantly makes me think of the COVID-19 pandemic. There's a fascinating shift in who is getting injured and where, specifically because of how we had to treat the virus.
Yeah, that was a really unique situation.
Yeah.
Starting in 2020, intensive care units around the world were flooded with patients suffering from severe ARDS, acute respiratory distress syndrome.
Where the lungs become severely inflamed.
Yeah, they literally fill with fluid, making it impossible to oxygenate the blood. So to save these patients, ICUs widely adopted prone positioning.
Which means flipping them over.
Exactly. They placed them face down for up to 16 hours a day to take the weight of the heart and organs off the lungs, improving oxygenation.
It was an incredible intervention that saved countless lives. But mechanically, flipping the patient face down flipped the pressure map of the human body.
It took the immense pressure load off the traditional danger zones, the sacrum and the heels, and shifted all that weight directly onto the face, the chin, the collarbones, and the knees.
Areas that are definitely not used to that.
Not at all. These are areas of the body that almost never sustain that kind of intense, uninterrupted mechanical pressure. As a result, medical journals were suddenly flooded with case reports, documenting a massive spike in severe facial and chest pressure injuries.
Wow.
It was a stark, tragic demonstration that if you change where the pressure is applied, the mechanics of capillary collapse will follow right along with it.
Okay, if the damage is starting deep against the bone, invisible to the naked eye, and it happens this fast, a nurse or doctor can't just rub the skin and hope for the best, right? Because these injuries are so deceptive, many of our historical, quote-unquote, common sense medical traditions have actually turned out to be actively harmful.
Oh, absolutely. Interventions that seem perfectly logical on the surface often fail disastrously when tested against the actual cellular pathophysiology.
Let's talk about massage, because this blew my mind. For a very long time, it was standard nursing practice to vigorously massage reddened, at-risk skin.
Right, the logic seems undeniable. Rub the skin to stimulate circulation and bring blood back to the area.
But today, this is strictly contraindicated. Why?
Well, if we think back to the mechanics of ischemia, it makes perfect sense why massage is terrible. The muscle and tissue under that reddened spot are already starving for oxygen. That starvation makes the cell walls incredibly fragile. So when you apply forceful, deep massage directly over hard bone to tissue that is already dying, you aren't waking up the blood flow. You are physically crushing, shearing, and destroying whatever viable fragile cells remain.
Oh, man.
You are accelerating the necrosis.
You're literally popping the cells.
Yeah.
What about the famous turn every 2 hours rule? If you've ever had a family member in a hospital or nursing home, you've heard this. It is practically gospel.
It is arguably the most quoted piece of pressure injury advice in existence. But the data tells a much more nuanced story. In the early 2010s, a major NIH-funded multi-site trial called the TURN study looked at nursing home settings.
And what did they find?
They compared repositioning patients every 2, 3, or 4 hours, while ensuring all the patients were placed on high-quality, modern pressure redistributing mattresses. There was no statistically significant difference in pressure injury rates across those time intervals.
So the rigid 2-hour clock was more tradition than hard science.
It traced back to older nursing customs and Kosiak's early physiology work, but it just became codified as a universal law. Current best practice realizes that a rigid, one-size-fits-all clock is deeply flawed.
Because every patient is different.
Exactly. It ignores the quality of the mattress, the patient's nutritional status, their skin moisture, and their specific biological risk profile. Care has to be individualized based on the patient's actual needs, not a generic alarm clock.
We have to talk about the donut cushion.
Oh boy.
The classic ring-shaped foam cushion. For decades, if someone had a bed sore on their tailbone, you'd give them one of these to sit on. The logic seems flawless. Put the wound in the empty hole in the middle so there's zero downward pressure on the injury itself.
Seems perfectly logical.
But wait, if you put a firm foam ring around the wound, wouldn't all of the patient's body weight just sit directly on the ring? Aren't you just choking off the blood supply in a circle all the way around the wound?
A circle that completely accelerates tissue death, exactly.
Unbelievable.
It's a brilliant example of how intuitive mechanics can betray us. You are building a tight, heavy fence around the injury, concentrating all the mechanical pressure onto the rim. By doing that, you completely cut off the vascular supply to the surrounding healthy tissue.
Wow.
You're literally starving the exact area that needs robust blood flow to deliver healing nutrients to the center wound.
It's the ultimate good intentions, terrible execution device. I guess it took the development of sophisticated, holistic tools to finally operationalize all this science correctly. and get rid of things like the donut cushion.
Yeah, tools like the Braden scale, which was developed in 1987.
What does that do?
The Braden scale took all this complex theory and turned it into reliable bedside math. Instead of just guessing who might get an injury, it scores a patient based on 6 specific factors: their sensory perception, skin moisture, activity level, mobility, nutrition, and their exposure to friction and shear.
So it's a comprehensive risk assessment.
Exactly. It finally gave clinicians a predictive model to flag the invisible mechanism before it became a visible disaster.
Zooming out from the individual hospital bed, understanding this mechanism has completely reshaped healthcare on a macro level, right? In October 2008, the U.S. Centers for Medicare and Medicaid Services, CMS, made this monumental financial ruling. They classified severe stage 3 and stage 4 hospital-acquired pressure injuries as never events.
Never events, meaning they declared that these injuries should simply never happen if evidence-based guidelines are followed.
Because they're preventable.
Right. Because the mechanical cause is so well understood and largely preventable with proper protocols, the government decided they would no longer subsidize the failure to prevent them.
Wow.
Medicare simply will not pay a hospital for the extra treatments and prolonged stays incurred if a patient develops one of these severe injuries while under their care.
So overnight, this mechanistic understanding turned pressure injury prevention from a basic bedside nursing duty into a massive multi-million-dollar financial priority for hospital administrations.
Huge priority. And the application of this science extends far beyond the walls of a hospital, too. Understanding how capillary closing pressure works is fundamental for biomedical engineers who design specialized seating and wheelchair cushions for paraplegics.
Oh, that makes sense.
It's even a major area of study for aerospace medicine. NASA and other agencies constantly monitor astronauts and subjects in long-term bed rest studies to ensure their skin and tissue don't break down at zero gravity or prolonged confinement.
Because the human body's requirement for continuous cellular perfusion is a constant, whether you are lying in an ICU bed in New York or floating in orbit on the International Space Station.
It's universal biology.
It really puts into perspective just how incredibly delicate our biology is and how heavily we rely on our subconscious alarm systems to keep our tissue alive. Before we wrap up, I want to leave you, the listener, with a final thought to mull over. Our research touched briefly on a deeply unfair biological concept called reperfusion injury.
Yes.
We've talked extensively about ischemia, how sustained pressure starves the tissue of oxygen and kills it. But there is a cruel twist. When the pressure is finally relieved, like when the patient is finally turned and the blood rushes back into that starved tissue, the sudden return of oxygen actually causes a massive secondary wave of destruction.
It is a devastating biological paradox. The tissue is starving for oxygen, but when it finally gets it, the sudden influx triggers the creation of reactive oxygen species.
What does that actually mean for the cells?
Well, to put it simply, when oxygen rushes back into a starved, damaged cell, the broken cellular machinery can't process it properly. It turns the oxygen into toxic free radicals, reactive oxygen species, that act like microscopic shrapnel, tearing apart the cell membranes from the inside.
That's horrifying.
The blood that the tissue desperately needs becomes a secondary mechanism of injury.
It's like throwing lighter fluid on smoldering embers. And knowing that the worst destruction is happening deep under the skin at the muscle bone level, fueled by these reactive oxygen species long before anything is visible to the naked eye, well, it really makes you wonder about the future of medical prevention.
Oh, absolutely.
If ischemia, shear, and reperfusion can do so much hidden damage so incredibly quickly, how long will it be before wearable technology or smart fabrics in our clothing can monitor our microvasculature in real time?
That would be a game changer.
Imagine a smart mattress or a pair of sensor-woven pants that can monitor blood flow and alert us to localized capillary collapse before the damage even begins. Keep that in mind the next time you instinctively shift your weight in your seat.